um, our discussion last time, this is pertaining to the awareness that we should actually have when we take care of our patients. There are so many concerns that we have to deal with when we consider our own personal emotion, our own personal psychological makeup, and psychosocial makeup. So it will definitely affect the way we take care of our patients. Can you hear me? Loud and clear, right?
Yes, doctor,
Yeah,
we can hear you.
Right, good. So you can interrupt me if you do not understand or if you cannot follow me so that I may
Okay.
repeat.
Okay.
Okay, so I was discussing earlier. Let us try to review then before I'm going to proceed with what nurses will be concerned with when they take care of your patients eventually. So let us try to look into our personal reaction first as nurses. This was discussed last meeting, but I would like to emphasize and I would like to review this now for your own benefit. Increase awareness of the reactions that influence objectivity. You see, our personal reactions must always be unnecessary. Remember, when we walk into our world, we stop becoming a family person. We stop becoming our own person. Instead, we are going to start becoming a nurse. That means all our personal prejudice, all our personal problems, all our personal concerns will be left behind so that we will enter into the new dimension. In that case, our judgment as regard to the condition of our patient, as to regards to the decision that we are going to make to our patient will be unimpeded, will be very objective so that we can render nursing care properly. So that's the main point. That means you forget everything, you forget your problems at home, and when you join your workforce, when you join the world, you are entirely a new person. That means you are a nurse in its entirety. Number two, identify reactions frequently experienced by other nurses to ease feelings of guilt and resentment. So once in a while, we have to observe what went wrong to other nurses. Most of the time, sometimes, you see, if you're going to look at other nurses, they're also human beings. They are overcome by personal problems, family problems, personal burdens. So we are going to observe them. It's not that we are going to be very condescending. We're going to look at these negative experiences to enrich us psychologically and emotionally. No? Then increase understanding of colleagues' reaction to enhance the work environment. So we have to continuously study what go wrong. We take the good side and we discard the negative things that we observe from our colleagues. Facilitate self-support by reducing self-criticism and reinforcing skills. We need to have a very good self-esteem, a very good look on ourselves. We should have to have a very good self-worth. That is actually the thing. The moment we are going to have that, we are already high on the mountain. We can always deliver. If our self-esteem is high, we can always deliver. We can always give. That's the thing. Select better assessment tools to identify patients' dilemmas and responses. Nurses are supposed to be very dynamic. See, we try to find out what bothers the patient. We try to find out what are the things that will concern the patient. The moment we can enter into the life of the patient, that is psychological, emotional, spiritual domain of your patients, then you can gain already their trust. The moment that you gain their trust, we can establish rapport and we can deliver our nursing care properly. And of course, number six is recognize how personal reactions to patients can influence assessment, planning, and effective intervention. As I was telling you last meeting, and you know, it's very important that we will take note about our cultural sensitivities, our cultural diversities. We have to respect culture. That's why there is the so-called concept of transcultural nursing, because we will be concerning ourselves in respecting the culture of others, including religion, including personal belief. That is the thing. We need to judge our patient based on what we see. That is the thing. And of course, we have to remove ourselves on that particular judgment as we go on. right? Now, I think I finished discussing this last meeting. I really would like to emphasize this because this will be laying down the foundation of what we are going to tackle next. And these are the following. The role of psychosocial nursing in managed care that I started also last week or last meeting. Our patient safety. Now, patient safety in psychiatry, this is number one consideration because as I mentioned to you earlier, again, the patient may be in danger, no, in their own making, in their own word. They may actually commit suicide, especially those people with depression. As I mentioned in my previous example, there are many patients who are very concerned about the payment that they are going to make in the hospital. So they would rather kill themselves rather than be treated and become a burden to the family. That will be a no-no to them. Sometimes they commit suicide just because of that. Okay, so we have to make it sure that patient safety is always observed. Psychosocial care incorporates these patient safety measures as a routine part of practice by maintaining, now, number one, open communication. We need to find out what bothers them. The moment they open up, then they are safe. But the moment that we found out that they cannot open up, then we will try to find a way so that they will open up. That is the thing, no? Then lifespan issues is another thing. Now, you learn in your nursing education that we have different stages in our life. The way we treat our patients from different stages of development also must be unique. We treat patients who are pediatric patients, we treat adult patients, and at the same time, we treat all age patients differently because we need to have understanding on the role that they're playing in that particular stage. You know that, no? That I discussed last time. And I think I stop from here. So I really would like to continue with number three. That is collaborative management. No? So the nurse need to know when work needs to be shared or delegated through referrals. We should know that we're not going to be standalone in the hospital. We are a part of a larger group. So we have to manage your patient properly. Therefore, we need to connect with other people. If there is a psychologist, if there is a psychiatrist, if there will be respiratory therapist, diabetic educator, infection control manager, we have to collaborate, including dietetics. Everyone is a part. Cleaners also are part of our managed care setting, managed care setup. So we will actually communicate with them. That's why we need to collaborate. Okay. So number four, as I mentioned to you, I think no patient education is the most neglected part. I believe before you came to my class, you had already your class in health education. This is the most neglected part of our class. You see, of our practice. Although this is one of the most fundamental role that we have to play in the world, next only to health caregiver. Nurse as caregiver, that's number one, because we have to manage the care. Number two, nurse as nurse educators. That is the most neglected part. Now, in patient education, we are going to make it sure that this is going to be starting from the beginning, the time of admission. You see, we have to initiate education already or health education from the time of admission. You see, if the patient does not know what's going on with him or with her, he is very anxious, is going to be afraid. You see, you need to provide adequate education so that you will be able to alleviate some psychosocial issues of your patient. This is number one also again. The moment the patient comes in, all this source of problem will also come in. See, fear, because they do not know, especially those people who will be undergoing operation, fear of the unknown, anxiety, especially when they are the sole breadwinner of the family. Along that line, we are going to make it sure that the patient will be able to be educated in such a way that you can alleviate the sufferings of your patients also. So number 5, all right, I think I stop here. Now let's proceed with how we are going to observe and make proper charting to our patients or with the condition of our patients. Now remember this, we are not supposed to be automatically charting everything and sometimes cut and paste. This is always some of the things that we are doing in the hospital, cut and paste and change the value. Sometimes nurses do not observe. Now, what do we do? Every single change of behavior that you can observe from your patient record. Patient's emotional responses and behavior must always be recorded because this may indicate something, so that appropriate responses and intervention may be done by by us and other the healthcare team members. Now, the increased use of computerized documentation can present new challenges, of course, no, because it's cut and paste. You know, I do not know what you are using in Abu Dhabi, but in Ras Al Khaimah, we are using Warid system. What system do you use in Abu Dhabi?
In hospital,
Yes,
we call Salamatek.
Salamatic. It's
Yes.
like Warid most. You can connect with IMO 8 or you cannot.
Actually, only from Abu Dhabi to Al Ain, another area we cannot connect.
You cannot, yeah, okay, because that's also another problem, interconnectivity, no? Northern Emirates, I think, use Warid system, the Ministry of Health, no? So there is impossible for us to communicate. I mean to say, our system cannot communicate. But somehow, this is also a challenge. You know already what I mean. Sometimes we just click, right? We just tick, our observations. And sometimes nurses, human as we just do cut and paste, isn't it? Tell me honestly, right? Cut and paste,
Yeah, exactly.
change the value, and then that's it. So our observation may not be read anymore. Our observation may not be very objective anymore. Now, as much as we can, we need always to observe. One of our main job is to look into some of the problems that we will observe from the patient. That is our main job. Observe the patient and chart whatever changes we can observe from the patient. Especially since we are learning psychosocial nursing, especially changes in behavior. You will observe changes in behavior. No, sometimes it's almost automatic as the patient sleep well. It does not say anything. If the patient sleep well, isn't it? It's not a red flag. So most people who will read that will just ignore it. It does not make any difference, right? But if you're going to say the patient is staring at the ceiling for about 5 minutes, the patient also is observed to be quiet and wanted to be alone all the time. These are all catchphrases that may get the attention of those people who will read that. The nurses, the doctors, you see? So if you're going to record that objectively, the people who will read that, of course, will pick up the problem and will reinforce whatever nursing interventions you're planning to give to your patient. Sometimes we have to do nursing intervention according to the needs of your patient. That is exactly what we are going to do, isn't it? So we have to be very careful in trying to do charting. It's not only an automatic. Charting is a very important part of nursing care. So we have to be very careful in recording what we have. We have to be very objective. We try to observe as much as we can. Now, how do we observe? We need to be in contact with the patient. How do we be in contact with the patient? We have to go on the patient bedside. You see, we have to observe, we have to talk. The moment we do that, we establish communication. At the same time, we are actually following up with the patient and we are observing the patient. And we also are conducting patient education in that manner. You can do so many things at one time. So that will be one of the major things that you have to do. Record everything that you observe, particularly in terms of behavioral and emotional responses. Right. Now, what about community-based care? Now, always take note, patients are not staying long-term, not unless they are psychiatric patients. In United Arab Emirates, we have only one major psychiatric ward, a psychiatric hospital, and that is located only in Dubai. In Al Ain, we have one, but it's a part of medical ward, right? It's, I think, medical tree in Al Ain Hospital. You know
Yeah,
that, right?
yeah, yeah.
Mhm. Actually, it's not a long-term facility. So most of the time, patients are coming in and going out, right? They will not stay there for long time. So most, yeah, yeah. You would like to share something? Uh, they will not stay there for long time. They will be discharged to the community, to their family members. You see? So now what will the family members do? We need to make it sure that will be very helpful in community-based care. But many patients require care that crosses settings. For instance, from hospital-based care to home nursing care. What are we going to do here? Definitely, when you are going to discharge them, they will be left on their own. They will be lucky if there will be nurses in the community. If we have a community hospital or health center there, they will be very lucky. So that's the thing. Okay. Then to ensure continuity of care, planning for the next level of care should begin as early as possible also. So patient education is necessary. Endorsement to the community is necessary. Now, some community setting is actually very wonderful because after discharge, the hospital communicates with the health center, and the health center is the one that follows up. I work in Malaysia for so long. I taught there also, and the setup is also very good. You know, the moment you are being discharged by the hospital, immediately the community where you belong to will be alerted that you are there being discharged already. So immediately a day after you are being endorsed, a nurse will go to your house and follow you up. That's the thing. So it's very good and very essential setting that I admire. I hope we have that facility also. No? So that's the thing. Because we need to make it sure that there will be a continuity of care. All right. Long-term care, like in some other rehabilitation centers, outpatient rehabilitation, other outpatient programs and whole care are now used for many patients. Most of the time, they do not want to stay in the hospital. They would like to be at home because you know why? They will be connected with the family members. They will be taken care of by the family. Therefore, there will be emotional connection, there will be emotional care, there will be psychological care, there will be psychosocial care. They have plenty. That's the thing. But in acute care setting, like in the hospital, emotional care is cut, psychosocial care is cut. So what do we do as nurses? What do we do as healthcare workers? We have to fill it in, isn't it? That's our job. But of course, it will be very difficult to do. It's easier said than done, right? Because they are not our relatives. They do not know us and we do not know them. How can they trust us? So that's why, as nurses, the first thing that we have to establish when we are going to take care of our patients will be trust. So that we can gain the rapport, so that we can always deliver psychosocial care the moment we do that, isn't it? You observe some patients, if they will trust you, they can easily confide to you their problems, right? I believe you're all veteran nurses. Now you have been in the nursing profession for a while. So you know what I'm trying to say here. That is the first thing. They cannot even receive injection. They do not want even to receive injection from you if they do not know you. The basic thing that we have to do is to establish trust so that we can deliver psychosocial care. Remember, as I mentioned to you, the moment a patient is situated in an acute setup like the hospital, immediately psychosocial care is cut. So who will give that? It will be us as nurses. So the first thing that we have to do is establish care, establish trust, so that we can communicate easily with the patient. The moment we do that, everything will be okay. Now, nurses in all these settings must also consider planning for the next level of care. We need to plan as we go. Now, what are they going to do in community? What are they going to do when they are going to be discharged? You see? What will they do when they're going to be discharged? Now, in our patient education, as much as possible, we have to involve the family members. But of course, it will be very difficult because sometimes family members may not come or may not spend a single minute to sit down with the patient so that you can educate them. You can do patient education. The only thing that you can actually do is to deal with the patient and do patient education with them so that they will know what to do. And of course, as I mentioned earlier, we can connect with our healthcare setup in the community so that the community will follow because they will be alerted in such a way that they know that this case is existing in the community. So that's the thing. I think it can be done, no? In United Arab Emirates, there are very beautiful health centers. We can still improve, no? Because we will do home visit. Now, I think there will be a point, there will be a time that these two and other healthcare agencies will communicate with one another. I think we are starting first with our health informatics, where we communicate with, I do not know if the health centers in Abu Dhabi are also equipped with the system that you are using in the hospital. If that will be so, then that will be okay in such a way that they will be alerted when the patient will be discharged so that the following day we can actually follow them up, those people in the community. So that's our progressing role as nurses supposed to be. So we have to plan. How do we plan and what do we do in planning? We have to start planning from the beginning. We have to start planning immediately after admission of your patient. That's what we are going to do. No, as psychosocial nurses, nurses with knowledge in psychosocial care. All right. Now, if you are working in hospital with psychiatric patients, we can usually use some of the knowledge that we have or that we've been using in psychiatric home care, particularly for patients who are having some sort of cognitive disorders. We are equipped with knowledge in how to handle crisis intervention. See? Anyway, a family with the patient in the hospital is already under crisis. Always take note. You see, we're supposed to be living normally at home with optimal health. But the moment we are going to cut them, then there will be a crisis at home already because one of the family member is missing. One of the family member is in the hospital. One of the family member is sure or is not sure to be dead or alive when they go out. You know, because there is a saying that goes like this: the moment you enter the hospital, you are 50-50. No? If you get out of the hospital alive, you are very lucky. That means you are discharged. If you will get out from the hospital dead, then you are unlucky. Yeah. So that's actually what they are telling. That's the reason why any family whose family member is in the hospital, whether it's because of certain reason, minor reason, they are still on crisis. Why? Routine is affected. Emotion is disconnected. Relationship is also affected because they will be missing one another. Anxiety is there. And also the problem including financial disaster if there is no insurance. So you have to know how to do crisis intervention. And we are going to take this in our future setup. Suicide risk assessment. As I mentioned to you earlier, the first thing that we have to look into will be the patient safety, isn't it? Patient safety. Because the patient will be, the moment they are going to enter into the hospital, they will be in danger of being injured. What kind of injury? it could be self-inflicted injury, or it could be hospital-afflicted injury, or it could be an injury that could be given by the patient. In that case, they have the tendency to become violent. So we are going to look into this. When I say suicide risk assessment, it's a skill that we have to teach you. All right? Then I'm going to discuss with you about this as we go on, because as the dean discussed with you, we have at least zero point 0.5 hours of unit of skill. So we will teach you how to do this. Crisis intervention, suicide risk assessment. We're going to teach you also MMSSE, mini mental skills assessment, and so on and so forth. No, so we are going to look into that. So management of psychiatric medications and blood level monitoring is also very important. So that's the thing, no? And then administration of long-acting injectable psychiatric medications must also be there. And we should instruct the patients also in such a way that they will know how to do and what to do. Counseling and education. These are the most common psychiatric interventions that we teach our patients. Assessment of patients and family coping. This is one of our responsibility. We have to find out what are the coping mechanisms that the family members would be using. Anyway, next chapter we will be discussing about coping mechanisms and defense mechanism that can be utilized by every single individual, and of course can be utilized by nurses. After all, we are human beings. We are the same with the patient in terms of that. No? Then of course, next one is safety assessment. Safety assessment is one of the most fundamental thing that we have to do also in the hospital. We are going to make it sure that the patient will not fall. We're going to make it sure that we're not going to have undue injury as a result of our carelessness in giving injection, in giving intravenous infusion. Of course, we are going to take care of the patient not to fall along that line, among others. Okay, so these are some of the interventions that we'll be learning as we go on. We will be teaching you in skills. Dr. Richard and me, and if the time comes, if the dean has time, then he or she will also be participating. We are planning to have a little bit of workshop pertaining to this. So Dr. Richard will be tackling at least two subject matter for our course. So he'll be teaching on at least 6 weeks video also. All right. So let's see. Not too much to discuss because everybody knows this, but I would like to remind you about patient privacy and right to confidentiality. So if we are going to be professional, the records, all the details of the records, or anything, particularly in terms of psychological problems of the patient, must not be divulged to anyone, including the family members. You see, you do not need to entertain calls coming from the outside, especially when they ask about the condition of the patient, particularly in psychiatric setup, because there is a danger that the one person who is calling on the other line may be different from, or maybe different from what they know, or they will be using the information that they can get from you for unknown reasons, for anything, no, for extortion or to destroy you. So that's the thing. I do not know if you are allowed to answer calls in your hospital, no? Asking about the condition. Are you answering calls and telling the condition of the patient? Can you educate me on this in your area? Because I really would like to find out about what's going on in your hospital also. When somebody calls, let's say I ring your phone and I ask you, do you have a patient condition like this, so and so? Do you answer phone calls asking the condition of your patient, class? Anybody can answer? Wapa? Shaika? Hello? Yeah.
Yes, sir.
You are still there? Yeah.
Yes, we are.
I'm asking, educate me. Let's say I am someone. I
Mhm.
I I I would like to call. Yeah. I would like to find out if the patient is there, and I would like to find out what is the condition of the patient. Do you give?
Do you
Hi,
need
I'm Dr. Ranel. You have a patient named Wapa. Can you tell me her condition? See, let's try to decide. No?
sir?
What do you think?
Again, doctor, my it was I was left from the meeting.
No, I know. No, let's say. So let's try to look into the privacy and also the confidentiality. Are you entertaining calls from the outside, asking for the condition of the patient? Let's say I am calling. Hi, good morning. I'm Dr. Ornell. Do you have a name? Do you have a patient named Wafa? How is
It's
she?
not allowed, sir.
Okay. So it's a
not allowed.
policy, no? It's not allowed,
Yeah.
isn't it?
No,
So
it's not allowed.
it's not allowed, even though they are going to insist that we are relatives, I'm the mother, I'm the father, and so on and so forth. It's not allowed, isn't it?
No, it's not allowed. Yeah.
We are not supposed to do that. Very good. At least you know already. No, basically it's just like this. So we have to maintain the confidentiality, and at the same time, we are going to maintain what we call as the patient's privacy. Under no situation that the patient condition will be told online, will be told through the phone. So that's the thing. So as nurses, we should know the rights of the patient. No, patient's rights are becoming increasingly emphasized in all healthcare settings, no matter what. So as if we have not seen the patient. That is the thing when somebody is asking. Not unless they are the visiting doctors. We will not even divulge from our fellow nurses. That's the meaning of patient privacy. That's how important patient privacy is. And also with their confidentiality. In fact, we cannot even print, isn't it? In your system, can you print? Maybe you can print one, right? But of course, you have to sign for it, isn't it?
Yeah.
And when you are actually logging in, I think everything will be recorded. Sometimes they are plugging you when you are going to see the patient's record for so many times in a certain day or in a certain time frame, right? They will be asking you to explain why is it that you are looking at this patient's record for quite some time, because our system can detect that, right?
Yes.
This is very important, no? Because we are not supposed to tell. That's how we reassure our patient. The moment we're going to start dealing with the patient, we are going to tell anything that you are going to tell here or that you are going to tell me will be treated as confidential. No one will know, including your relatives. It will only be between you and me. The moment you're going to do that, they can trust you. You see? Then you can ask all the questions from the patient already. And of course, you do not need to share. In that case, you're already giving psychosocial care. Why? You initiated the care, you established the trust, then the moment the patient tells the problem, they are unburdening themselves already. Less of a burden, less of a stress, less of anxiety. And the only thing that you can actually do is assurance. How do you assure them? By holding their hands and by smiling or by nodding your head, isn't it? In that case, you're already giving psychosocial care to your patient. And of course, we have always to consider a code of ethics, no? This will be very, very essential. Of course, we became professionals just because we know this. And I do not need to dwell more about this, no? All right? You understand
Yes.
what I'm trying to emphasize here? Okay.
Yes.
Now, most of the time, when we are going to deal with the psychological problems and psychological problems, we will be using the Diagnostic Statistical Manual 5, version 5. This is designed by American Psychiatric Association. They released last 2015 the latest version of this. This is like the guideline where we can always look into and compare the conditions of our patients so that we can actually make a very good diagnostic criteria. I do not know what you are using in your system, but I believe there will be a system that will help you in diagnosing to establish your insurance policy also. I think you are using ICD-10 or ICD-11 or still 9. Are you familiar with that? When the doctor makes the diagnosis, isn't it they just click and click and click, right? And that one, I think they use ICD-9, isn't it? Or ICD-10. Also, although there are versions. Are you familiar with that?
For me, sir, it's different. In police, it's different.
You're in police, no?
Yeah,
Okay.
it's different.
So, why it's different? You are not connected
Because-
with the system in the hospital?
no, at all. It's secured. It's
It
not
is
allowed
secured
to.
also.
Yeah.
Yeah, okay, police. I have a student in Arin Basin also who is working in the police now. And sometimes in the clinic, it will be very difficult. Tell me the system of police in your area. How many are you? How many nurses? Is it a clinic or is it like in Dubai?
No, it's in Abu Dhabi. It's a clinic.
I mean to say it's like a hospital catering your patients and at the
It's
same
open
time
field. Yeah.
including the family members of the policemen, right?
Yes, yes,
Policemen, the family members of the policemen, and also of
yes,
course the prisoners in case, or maybe
yes,
the people who are getting arrested, yeah, so things like
yes.
that.
Yeah.
So everything is confidential, and they use whatever you have in judicial system. That's forensic psychology, you see. By the way, in most of the hospitals that we have here, they are, I think, using ICD-9 or ICD-10 for insurance purpose. They just tick and tick and tick, no? And but for psychiatry, we need to look into diagnostic statistical manual 5. This is very essential and this is very important. All over the world, we keep on using this. Now, because diagnostic statistical manual 5 covers all categories of mental health disorders. Here there is already gambling addiction. So this is one of the problems that we may have here. Gambling addiction. Maybe on another release, they will include here internet addiction. Internet addiction is actually coming. We have heard about this in our circle. So that's one. We are classifying or declassified all the mental disorders in this, and we utilize this to make a necessary diagnosis, no? Because this contains description, symptoms, and other criteria necessary for diagnosing mental health disorders, no? So that is very essential when we are going to use that. In psychosocial nursing, it's similar. In police force, it will be very difficult because we are not sure, especially those who are actually coming in. Sometimes uh, I do not know if you are dealing with drug addicts also. Are you dealing with the people who are arrested yet or no?
For me, I'm working in jail. So I'm
You're working in jail also.
yeah, for juvenile people, any less than 18 years old.
My goodness, you will be using a
Yeah.
lot of psychosocial nursing care
Honestly,
there,
yes. I'm
isn't it?
dealing with the drug also addict people,
Yeah,
teenage, and this one, some criminals.
some criminals. You have to understand them because they are human beings also. That's the thing. So human
Yeah,
beings, that means to say we have to treat them equally as if they are patients. That's what we should do. They have problems also. The reason why they are there is because they have problems. Why is
yes,
it that
yes.
they are running against the law? They have problems. So we have to look at that as we go on. Yeah, I'll give you
Yes,
some techniques how to handle them, particularly on violent patients. There are violent patients, of course. We have to deal with
and
that.
rude, and they are very rude.
They are very rude also. How are we
Some,
going
yeah,
to? Yeah, I will teach you. We will teach you how to do that. Don't worry.
inshallah, inshallah.
Yes. Okay. So that actually that ends our first chapter. I will proceed now with the next chapter. We still have some time. I would like to start with that. No, and it's more. It's every chapter is very important. By the way, I will give you the books I believe the dean told you that we have 3 books now. Actually, 4 books. We have 3 books. I will be giving you the books later on. I'll give you instruction on how to access them, and including the PowerPoint that I'm using, how you are going to access them. So you are entitled to that, so that you have something to follow through, you have something to read. Okay? So I will teach you how to do it later on. All right. So I'm going to proceed with the next one. Psychosocial response to illness. So this is chapter 2 of our textbook. This is also very essential, and this is very important. Here are the learning objectives. I do not need this to read. This is only for my guidance, but if you would like to, please read them also on your own so that you know what we would like to discuss. No? We are going to look into self-esteem, looking into body image, looking into powerlessness, looking into guilt, then looking into patient's emotional response to illness. And also we're going to look into Maslow's hierarchy of needs. Then we're going to look into defense mechanism and coping mechanisms, and we're going to look into how we can enhance them. So that's the thing. So I would like you to focus on that, because this may be applicable to you also as a human being. No? This is the wonder of understanding psychosocial care, because it may be applied to us. As human beings, we do have our problems also, isn't it? As human beings, we have also our concerns. So we can always apply this so that we can take care of other people also. The first thing that we need to do as nurses is to take care of ourselves before we can take care of others. So that's essentially what we need to believe in. All right? So now, psychological impact is present in any illness. In prison, look at this. Hospital is like a prison. Why? Because you are not at liberty to go home for 1 or 2 or 3 days the moment you are admitted. Right or wrong? There will be guards all over. In prison also it's the same. So they have only one thing in common. They are always severed of relationship. That means to say their family will be away for a while. Definitely there will be psychological impact. They will be afraid. They will be worried. And sometimes their freedom is curtailed, at least for a moment. They will not be discharged, not unless they are already okay. So we have to look at that, no? Now, that is the first thing that we have to address. In the hospital, that is the first thing that we have to address. Imagine you're going to be admitted in the hospital. Parents will bring you, husbands, children will bring you, but they are going to be actually staying outside only after that. So there will be emotional disconnection. Who will feel that? It will be you as nurses. That is where you're going to utilize your knowledge in psychosocial care. To fill the void, to feel the connection. That's why people who are arrested also in jail, you see, they are away from their family. That's why they are rude also. If you respect them, they will respect you. That's how we handle them. See? If we show that we will you will understand them, then they can actually trust you. So that's basically what we need to learn. Now, illness threatens the individual and evokes a wide array of emotions, such as fear. That's the first one. Fear of the unknown. Are they going to die? Are they going to survive this hospitalization? Can they afford the hospitalization? Can they trust nurses? Can they trust doctors about their lives? See? We are always emphasizing to our students that as nurses, the lives of our patients are within our reach, are within our hands. You see? Sadness will be there. The reason why some patients are rude, because they are angry. Where they are angry, with whom they are angry, first they could be angry with themselves. Because why did they allow that to happen to them? Second, they would be angry with their parents or with the world or the accident that could have caused that. You have to understand it. Depression. See, because they are thinking that they may not get over it. They are thinking that they will stay for a while in the hospital, so they cannot do the things, the usual things that they do. Despair, especially when they are breadwinner, especially when they have no family to look for. And of course, the number one thing that I would like you to know, loss of control. See, the moment you are in the hospital, you are not in control of your life. Who will be in control? Nurses, doctors, and also the other health workers. When you are in jail, who will be in control? The police, nurses, and other people involved in the care of those who got arrested. You see, they cannot go out as they wish. They cannot even eat as they, you know what I mean? Everything must always be looked in that way. Now, now each individual who faces an illness responds differently according to personality. So here comes already the personal experiences. If you're very resilient, that means to say you can easily take care of yourself, then hospitalization is okay. You know that you can get out. But the first time that you're admitted, I think it's a problem. No? Previous life experiences and also your coping style. No? I will stop at 5 minutes before that 3:30, and I'm looking at the time because I really would like to tell you how you are going to access the materials that you need for this course. No? Another one, just like loss of control, denial. See? Because they will not accept that such thing happened to them. Extreme denial. Of course, another one will be non-compliance, especially in psychiatry. Take this medicine, they will not take. Do this, they will not do. Sleep, they will not sleep. How are we going to help the patients? You see, do not move around, just sit down, they will not do. Play therapy cannot be done. On other types of therapies that we would be doing to the patient may not be done because they do not want to comply, they do not want to participate, they do not want to do things that we want. Yeah, aggression. That's why you mentioned about rudeness. Aggression, because they are out of control. They would like to show power. They would like to assert their power, but the reality is that they cannot. That's why they become rude. That's the thing. Also in the hospital, no? Especially they will show you some sort of, hey, I don't believe you anymore. You're not as good as this person, and so on and so forth. Or get out, something like that, no? And the threat of suicide will be there all the time. That's why patient safety must be considered, no? These are some of the maladaptive responses that you can expect from your patient. So nurses must always be on the lookout. And we have always to address this at all costs, by all means, at all times. Okay? All these reactions are only temporary and eventually it will subside, especially when the patients will trust you already. The moment the patient trusts you, all these problems, all these experiences may be wiped out immediately. You see how important a nurse is in the world. You see how important a nurse is who has a knowledge in psychosocial care. Because we will apply psychosocial care in every setup. Yeah? All right, moving forward. So now let us try to look into the characteristics of psychosocially healthy and unhealthy people. We have to compare. You have to review our mental health also. That's our major concern. Most of the time, we do not know that we are hurting ourselves already, yet we keep on working and working and working. We do not know how to rest, as if the word rests on us. So that's not a good thing. If that will be the case, then there will be a problem. So we need to make a comparison between unhealthy and healthy psychosocial health. You see? So let us try to see first psychosocially unhealthy. These are the people who do have problems. No? Number one, these are the characteristics that they may actually have. Noses for life. They are pessimistic. They are cynical. Most of the time, they are spiritually down, as if they do not have life to live for, as if nothing will beautiful happens to them in the future. They are pessimistic. They are always thinking as if they are down, as if they are no good. They laugh, but usually at others, and they do not have fun. Okay? Has serious bouts of depression once in a while. They're down once in a while. Or they're always sad, no? And sometimes they may have suicidal thoughts. Although in United Arab Emirates, suicide is actually unlawful act, but it's a reality. We have to prevent that from happening because people may think so also. Okay? A challenge to be around socially isolated will be there also. They would like to be alone. Although there are people who really would like to be alone, but they are healthy. Why? Because they are enjoying what they are doing, isn't it? But there are people, since they do not want to be with others because they feel so inadequate, they move, they retreat. So in that case, there will be a problem. Experience many illnesses, headaches, aches, pains, complaining a lot, colds, they may actually get infection. Their immune system could have been affected also. That is the case. No? They show poorer coping than most. They cannot cope with whatever problem they may have. They have a regular relationship with problems. One after another problem comes as if problem is always hunting on them. They are solving one problem after another. You see? So that's not good. No? Problems are around, but sometimes we have to go something like, problems are haunting them all the time. They tend to be cynical, critical of others. You see, they easily criticize others. And they tend to have negative and critical to friends. As if the friends are not doing anything good. As if their employees are not doing anything good. So that's the thing. All the things that they are doing, the friends, their employees, people under them are not good. They are bad. No? They lack focus of time, hard to keep intellectual equity, all right, and they are easily quick to anger. Sense of humor and fun is less. That's the thing. So these are psychosocially unhealthy individual. Of course, we experience this once in a while, but we can easily cope. What about psychosocial health? I'll just finish this. No? Work to improve on all areas. They have the capacity, they are open. They know that they are inadequate, but they are capable of improving. They have healthy relationship. Although no one they quarrel with their loved ones, but yet their quarrel is healthy. No? They are very good friends. And the friends love them. They give love easily, they receive love easily. No? They have a very strong social support. If they are hospitalized, you can see how important they are in the community. A truckload of people from the community will come in. No, because they have these good social skills. They have occasional emotional dips, yes, normal, but overall they are very good, no, mentally. They possess zest of life. They like to live. They have high energy, very resilient. They enjoy all the challenges that they are encountering. They have very good coping skills, and they are very realistic. They have sense of humor also. They adapt to change easily, no, and has very strong social support. That means to say they take everything positive. Problems are there, no, but they can solve it. They can get out of it. So that's the thing, right? I would like you to continue reading chapter 2 and you can download this, okay? The next thing that we're going to discuss, I think that will be Tuesday, will be the rest of this, including Abraham Maslow. I really would like to emphasize Abraham Maslow. I would like to talk about this more. The next meeting, it will be 2 hours. I would like you to be ready on this, no? No, I will not dismiss you yet. I would like to share with you where you can access, okay? Are you still there?
Yes, sir.
By the way, do you have any questions, Shaika? Shaika, where are you work? Shaika, where are you working again?
Police.
Police. Wafa?
Yeah.
Wafa, you're there? Okay. Maybe they're muted. All right. This is where you're going to get, no? I have a website. All right. Do you see now what I'm sharing on the screen?
Yes.
Okay. So this is my website. You can see me smiling all the time. I like this picture, you know. This these are our textbooks. I cannot send this to you because the files are so big, are huge. Okay. So these are our textbook. You can click them automatically. It will be downloaded in your computer or in your iPhone or in your iPad. Okay. Psychosocial aspects. Yeah. This is what I'm using right now, the third one. But we will be using all these three. Okay. So the chapters 1 and 2 will be, including 3, will be coming from the third one. Okay. So next one, the course syllabus that the dean presented can be downloaded here. All right. Click the here. Okay. And I'll be sending you an email, a link of this so that you can actually access. Now, for here, the first lesson that we have can be downloaded here, the PowerPoint. A psychosocial response to illness, the one that I'm presenting right now, can be downloaded here. Next will be psychosocial skills, can be downloaded here. All right. Our previous recording is also uploaded, so you can access the video here. You get it?
Yes, sir.
If you would like to review our previous class, you could review. You could you could see, no? Anyway, our faces, my face is only there.
Yes, sir.
So you will not be compromised, no? So I really would like to help you out so that anytime that anything that you miss, you could always go out. You could always go back and review. Okay. So the video of our discussion today will also be posted again here later on, so that you can review. Okay. So any questions so far? Is that okay with you?
Yes, sir.
Yeah. So you know now you can access already, all this video, all these books. So for free, you will not pay anything. You will not log in. You don't do use anything. All you have to do is to click download. That's it. Okay. So I'll be sending you an email later on. All right.
Okay.
So we're 3:30 already. Nice meeting you all, and I'm very happy to teach you again today. Okay. So,
Thank you so much.
remember to smile all the time and have a good day. Laugh at the problem.
Thank you so much. Thank you.
Not be healthy. Bye bye. Bye bye.